Our next speaker is my dear colleague from Southwest London Maternal Medicine Network, Dr. Ingrid Watt-Coote. She's a distinguished consultant in maternal medicine with an impressive 16-year tenure at St. George's University Hospital in Southwest London. Serving as the clinical lead for the maternal medicine service within the centre in Southwest London, she demonstrates unparalleled expertise in the field. Dr. Watt-Coote is a fellow of the Royal College of Obstetricians and Gynecologists and holds the esteemed position of preceptor of maternal medicine training in obstetrics. Beyond her clinical roles, she is actively engaged in teaching and contributes significantly to research in the realm of women's health, solidifying her commitment to advancing healthcare knowledge and practices. Ingrid is going to share with us her insight on maternal medicine as an obstetrician.
My name is Ingrid, and as Sarah said, that I work as an obstetric lead at St. George's Hospital in London. But first of all, before I start saying anything else about my talk, I'd just like to express my deep, humble, honored feeling of being invited here today to talk about maternal medicine. And in particular, this is a very sensitive feeling for me because this is where I started as an infant in terms of obstetrics. First, I'd like to talk about my journey and just a whistle stop. So my undergraduate years was at University of the West Indies. Then I spent my time in San Fernando, where I did most of my medical intern work, and then I started obstetrics. Then I started obstetrics at Mount Hope Hospital before I moved on to the UK. It was whilst I was at Mount Hope Hospital that I realized that obstetricians do not know much about medical disorders in pregnancy, and we never seem to understand how to care for these patients. And then Mount Hope Hospital, being a standalone hospital, make it very difficult to care for these patients. As a result of that, I spent just under 2.5, 3 years doing neonatology, anesthetics, and internal medicine to complement my obstetric training. I then, in 1996, started my obstetric training under the expertise of my dear friend, Professor Nelson Piercy, Dr. Sanjay Clark, both of whom are here, and you have heard quite a bit about obstetric medicine before from Professor Nelson Piercy, and you will soon from Dr. Clark. My obstetric training predominantly was at St. Thomas's Hospital, after which I moved on to my current post at St. George's Hospital, and I've been there since 2009. Now, St. George's Hospital is located in Southwest London, and the population of Southwest London is about 1.3 million. Population of Trinidad is 1.5 million. Southwest London, St. George's Hospital serves not only that 1.3 million, but further afield, a total of 3.5 million patients. And if you think about that, St. George's Hospital within Trinidad and Tobago can serve your entire population. It's a tertiary hospital, it's one of the largest in London and one of the largest in Europe. We have 1,300 beds, we have over 10,000 staff, and there's about 12,000 consultants. We have co-located neurosurgery, pediatrics, anesthetics, everything, including a helipad, which we can fly patients in from everywhere. Now, St. George's Hospital is located in a very diverse area of London. The population, about 57% of the population of Black, Asian, and ethnic minority groups, and 47% of this population were not born in the UK. As a result of that, you have a very diverse language, cultural beliefs, all of which we have to negotiate and get around when you're dealing with patients that we see in Southwest London. It's a very cultural area in London. So this is a picture that shows you what the London sub-regions look like, and the star just represents where St. George's is, just on the outskirts of central London, on the upper areas of Southwest London. Now, we heard about what an obstetric physician is, and I hope by the end of this talk I can tell you who a maternal medicine obstetrician is. So maternal medicine obstetrician provides care for women who have pre-existing medical conditions and pregnancy-related conditions. I'll just touch on, pre-existing medical conditions and existing medical conditions. And you can see we sit at the center of the care for the patients. We train maternal medicine consultants, we train and mentor postgraduate obstetric doctors, we train specialist midwives, we listen to other specialists and we collaborate with them. We are a champion of women and we are the center of the core of everything that we do. A big part of my job is to offer preconception counseling. Preconception counseling is essential in medicine and it's even more essential in obstetrics. In the ideal world, patients with pre-existing medical conditions, if they come to us having had preconception counseling, then that would be great. But we know that more than 40% of women, pregnancies are not planned. And for some patients, the diagnosis of the medical condition only occur at the time when they arrive for booking their pregnancy. In my clinic, I will review the medical condition, look back at the history, we will review medications, we will change medications, we will adjust and look at investigations, and then make a plan about how this patient's pregnancy will affect their medical condition and vice versa. We also review the obstetric history. For example, if this is a patient who has a severe preterm preeclampsia, and preterm preeclampsia refers to preeclampsia occurring less than 34 weeks. Now, as Professor Nelson Pierce has said before, preeclampsia can cause complications. Preterm preeclampsia is worse. Patients may end up with kidney problems and a whole realms of other conditions that you need to make sure that these have actually gone back to normal or not. You also need to talk about recurrence, what will happen in the next pregnancy, and plan for this woman. Some patients we may have to change medications, but it's difficult in some situations because pregnancy cannot be planned and say, I'm going to get pregnant next week, I stop my medications now. It doesn't work that way. And therefore, some medications will have to be continued until the first pregnancy test. And this you'll have to explain to the woman. A patient with kidney disease, if they're on, for example, ACE inhibitors and it's not safe in pregnancy, you stop it before what is going to happen to her kidney condition. She may take another 2 years before she gets pregnant. So we advise to continue until the first pregnancy test. We encourage patients to continue with a contraception, and we want reliable contraception. Rhythm method doesn't work. Condoms are rarely used on time. They're good for sexually transmitted disease, but it's not a reliable contraception. Reliable contraceptions, implants, intrauterine devices. Pills, patients never take them on time, and they always forget to take them. So the maternal medicine obstetrician also looks at the postnatal review. Now, pregnancy can change what happens with a medical condition. And therefore, and also during pregnancy, you may have changed medication, you may have changed or increased some medications that they're on, and therefore, postnatally, you need to review either restart their pre-pregnancy medication or reduce the medication dose that you have already increased. It's also an important time because you are able to introduce contraception and stress the importance of contraception. It's also extremely important, as Kathy said before, to get the patient back into ongoing medical care so they are not lost to follow-up. And it forms an ideal opportunity to offer some form of preconception counseling, and sometimes even say, when you're ready for your next baby, give us a ring, let us have a chat about what your condition is like, and therefore we can advise if this is a good time to get pregnant. So the referral pathway. Patients are booked in the antenatal clinic, and in the antenatal clinic they will refer to maternal medicine. These referrals are then triaged by our most senior specialist midwife with the help of the obstetric consultant, maternal medicine consultant. In order for the specialist midwife to effectively do these triages, we have pathways, disease processes, what to do and what not to do. Relevant investigations are ordered so that when the patient is seen in clinic, you can make a comprehensive assessment of this patient, examination, history, the medical records, and the current investigations. And then you can decide by a traffic light system, how soon do we need to see this patient? A week? Sometimes you may have to call the patient the same day that that referral comes in. 2 weeks, or just routine care. Following this triage, then the next step would be, yes, we can see this patient in the maternal medicine clinic for the entire pregnancy. We can share care with the other team, and we see them at certain points in their pregnancy journey, 28 weeks, 36 weeks, 34 weeks, or they can be discharged and say you'll be fine to their routine obstetric care. The result of this is that only the patients that have significant medical conditions or who we perceive may need more assistance in pregnancy that we'll keep. But that doesn't mean that the medical condition cannot change. Medicine is dynamic, things can change, and the patient can be referred directly back to us to be seen to have another assessment. Now, this is the current setup, and I've included this slide to show the maternal medicine consultant is at the center of the hub. And as you can see, the large group of different specialists, neonatologists, the obstetric physician, the obstetric anesthetist, and yes, I've included that in it because they're really, really important. They form a central part of what we do. The obstetric physician can coordinate the care of the woman within this hub. And this is how we do that. And why? As I said, we're the central part of the hub. Obstetric physicians understand the physiology of pregnancy. It's very different from the non-pregnant state, and if without understanding the physiology of pregnancy, you will not know how the disease process will affect pregnancy, or indeed how medications will change for pregnancy and dosage. For example, you'll have an epileptic on lamotrigine, increased filtration in pregnancy, the levels will fall. You have to, if the levels are low, you'll have to increase the dosage to maintain a good level to reduce seizure activity in pregnancy. And as an obstetric physician and a maternal medicine consultant, that is what we do. Training in obstetrics and maternal medicine uniquely manages pregnant patients. So just to recap, again, I've said to you what a maternal medicine consultant is. We are at the center and we coordinate the care of pregnant women within the unit, between all specialists, collaboratively working with all other specialists, and with the obstetric physician, the anesthetist, the neonatologist, and we bring everything together. We are unique in the sense that we are medicine trained, we are obstetric trained, we can deliver and look after patients from the beginning right through to the end. We can talk about what to expect from the baby at birth, we can talk about neonatal outcomes, and we can talk about postnatal complications and reviews. We also, as I said before, talk about pre-pregnancy counseling and postnatal review. Now, how do you build a network? So we know where the maternal medicine consultant sits. We know about the collaborative working with all the specialists around you, and how do we feed into that? We now have to get general practitioners, family medicine doctors, emergency doctors, community midwives, and district general hospitals. We need to be able to provide all of that network feeding into the service that we provide. And this is the only way we can reduce maternal mortality, maternal morbidity, and improve the care of the women that we serve. Now, how do you train a maternal medicine specialist? That's very challenging. Very challenging because there's no direct way of training. The Royal College of Obstetrician provides training for maternal medicine consultants or trainees who have an interest in maternal medicine, known as ATSM. But that doesn't go anywhere near to provide the level of expertise that they need to be able to function independently as a good maternal medicine obstetrician. The Royal College of Physicians now have the obstetric medicine postgraduate training, where Dr. Nelson Pierce has said that there's the diploma, which is at 12 months, and that's at 12 months on top of everything else that they have done. I run a service whereby I have clinical fellows, and these are trainee specialist obstetricians who have just completed a training. They are not yet consultants, but they have completed the RCOG training that spends a year working solely in maternal medicine to consolidate and solidify their maternal medicine experience. They will also work and go to clinics which are joint clinics, neurology obstetrics, renal obstetrics, hematology obstetrics, and in the high-risk obstetric anesthetist clinic, where it's only obstetric anesthetist, obstetric maternal medicine consultant, where we plan care for patient. And at the end of that, they've all achieved maternal medicine consultant jobs and function independently and confidently. How do you work with the other specialists? Communication. Communication is really important. Being available to talk to the specialists when they have a maternal medicine or an obstetric patient in their clinic, on their wards, is really, really important. Building that confidence, knowing that they can talk to you whenever there is a problem, and also, as you heard before, a pregnant patient should not be treated any differently from a non-pregnant patient. There are only very, very few exceptions whereby you will say, no, we won't do that, but we could do something else. But generally, they should be treated just as if they were not pregnant. How do you support them? You just have to be available. You just have to collaborate. And formal training of your specialist midwives, which is instrumental to this as well. Implementation of the service. How does maternal medicine specialists build around that? As I said before, collaborative working, joint clinics, ward rounds, MDTs. You need to go and see these patients. You need to examine the patients. You also need to review guidelines and pathways, which will all be on the intranet. They are available for your colleagues to look at. You need to build awareness of medical disorders in pregnancy, and you also need to deliver education sessions. This could either be through the form of grant rounds, this could be in the form of webinars. Post-COVID, we're very blessed in that we can do everything now online, Teams, webinars, and you can provide widespread knowledge, training, and development wherever you are. But funding is important. This cannot happen without funding. And you heard from the minister how invested he is into women's health, collaborative working, and you work with what you have. So the lessons I've learned. This was very, very challenging. I accepted that post in 2009, thinking that, yes, I'm going to set up a maternal medicine service, and this predates the maternal medicine network. The networks were non-existent then. And you think that everything would have been in place when you get there, but how foolish was I? You get there, and the maternal medicine service, that's you. There are no midwives, specialist midwives. You have lots of midwives, but no experience in maternal medicine. There wasn't even a place for you to say, this is my office, this is my desk, this is where I'm based. It all had to start from scratch. And the first thing I did was to say, well, we need 2 midwives. And we got 2 midwives, one for diabetes, and who had some diabetic experience, and another midwife who had some maternal medicine work in a district general hospital. But when they came and they started working, you realize that they had a lot of bad practices. What they considered to be maternal medicine and caring for patients was not what I thought was correct. So I had to train and develop and work with them. And boy, did they work hard. And I will take my hat off to them, because these 2 midwives have been instrumental in getting the service where we are now. And we still work together. They are working further afield in the wider network, but I have a lot to thank them for. We are in a completely different place now. We have good collaborative working. The specialists around the hospital, within the regions, and from other hospitals know exactly who to contact. We'll get message that this patient is on the way to see you, cardiac failure, bad kidney disease. terrible diabetes, and they know exactly where to go, and we're always there to accept these patients and provide the care. Working as an obstetrician in maternal medicine is very, very difficult. It is very challenging, and I'm not going to pretend that the work is easy. Each patient you see is time-consuming. It's never a 5-minute job. And in Southwest London, the language barrier, using interpreters, using words and terminologies, not medical terms that the patient understands. They go home, they meet in their community, and they say, oh, that's rubbish, don't do that. They just want to give you all of this. And they come back and they wouldn't do anything you ask them to do, right? So it is very, very difficult. You have to be their champion in these patients, get them on the same page with you, and then you'll get a lot of cooperation. When we started the referral process, just 2 midwives and myself, and we set up this triage so that the patients come to the booking clinic, the booking midwife will know exactly what questions, and you have to ask the right questions to be able to elicit whether this patient has a medical condition or not. We were overwhelmed. We were getting more than 200 referrals per week, but this is on top of your normal obstetric work. And to triage 200 referrals a week was not sustainable. So we had to make a business case to increase the capacity, so we got more consultants, 2 more consultants, and we got a whole team of midwives with whom we now work and set jobs, which makes it much easier. So this slide just illustrates that we always hope that it's a nice, smooth road to the top, and boy, it isn't. You'll fall, you'll get trampled over, and it's very topsy-turvy, but failure does not mean it cannot be done. We're dealing with people, people are different, we deal with patients, patients are different, diseases are different, and sometimes we'll make our way ahead and we get knocked back, but that doesn't mean that we shouldn't carry on. So what can St. George's and the UK do to support you? We can offer training to obstetricians, physicians, webinars, maternal medicine, set up educational sessions. We can share guidelines with you, and we can offer advice when requested. This could be email, WhatsApp. Everybody uses WhatsApp now these days. We can work at the entry point to implement what you currently have. There's no point trying to reinvent the wheel. You have a good setup here in obstetrics affairs, so what we would need to do is to work with that and build, because pregnant patients will always come in, pregnant patients have medical conditions, and this will always continue. So side by side, as you evolve the service, you'll have to look after the patients that you have here. And you have to empower the physicians, the A&E doctors, the medical school students, the physicians in training, the postgraduate trainees, that is, the obstetricians in training, that, you know, a pregnant woman is not a disease. They are unique. They do have medical conditions, and we're going to see more of it. Women are older, women are fatter, women have pre-existing disease that they know about, and pre-existing and disease that they don't know about. A booking blood pressure of 160, 100, 4 pluses of protein in the urine, found to have chronic kidney disease stage 4, severe hypertension uncontrolled, a cardiac problem, all diagnosed after the booking appointment. And this poor woman didn't know. She's diabetic with HbA1c of 100, present to you at booking clinic at 10 weeks. What are you going to do? The whole discussion you're going to have with her will change. You also need to be very, very honest and open with women. You need to tell them what that implies in terms of the care in pregnancy. You need to tell them that they will have lots of appointments in hospitals. You need to tell them that the risk to the fetus in terms of chances of preterm delivery. But also, you need to let them know that this doesn't necessarily mean that they will have a cesarean section. I see lots of patients in my neuro clinic, in my renal clinic, and they all seem to think a medical condition equals cesarean section. But you have to remember, people talk about they can't push Valsalva, but they do that every day. They lift weights, they go to the toilet, they open the bowels, they do that every day, and they never collapse. So pushing a baby out is not going to change that. One other thing that you can do to help to set up your service is to look at industries, charities, pharmaceuticals. They're usually very willing to say, oh, I was involved in setting up this clinic or getting equipment or machines, home blood pressure monitoring, instruments that patients can take home with them. And they usually are very happy to provide some funding for that. So far we've established our maternal medicine is at the center of the service hub. We have established how much training underpins the development of the maternal medicine network, and I've shared with you personal challenges we have learned in the UK. But please don't forget that the health system is dynamic. The demographics will change. It depends on what your demographic is, what your burden of disease is, and the age range of the patient. If what is happening in Trinidad is similar to what is happening in the UK, the average age in my clinic with medical disorders is probably 40 years old. Last week, I completed a clinic, and I was quite surprised that 3/4 of the patients were in their early 30s. It just hit me because I haven't seen that for a while. Patients are north of 45, and with advanced maternal age come a whole range of different conditions. You'll also find that a lot more patients are coming to you with IVF treatment. It's not unusual to find somebody in the early 50s who have IVF and have multiple pregnancy, cardiac condition, hypertension, and diabetes. This is the way the obstetric demographics is changing in the UK at the moment. How do you define success? It's not going to happen overnight. It will take time. Work with what you have. Look at what can happen in 5 years, 10 years, 50 years. You'll have to look at what is happening now. The doctors of tomorrow will not be the same as today. Things will change, medicines change, things are moving forward. Lots of the medicine that we use currently today may change because of increased development in better healthcare, what's available. And we have to move with the time. The new generation will have different priorities, they will think differently, and we have to, and different cultural beliefs, and we have to be prepared for that. So the future, short-term goals, less than 5 years, longer-term goals, and we have to look at what is achievable. So I won't dwell on this as we don't have much time at the moment, but I'd like to share with you a very, very interesting case. And this will show you the challenges that a maternal medicine consultant will have, and the complexity and the collaborative working that is really, really important to reduce morbidity and mortality in this group of patients. So this is a patient I have personally looked after. So she's now 35 years old, and she has had 2 children, and she's had 1 termination of pregnancy. It was very challenging. This is an Eritrean refugee who presented to us with bleeding and was diagnosed with pregnancy in the early pregnancy unit and was sent to the maternal medicine team. She lives in a hostel, no permanent place of abode. English was not her first language, obviously, but her English was not very good. She has a very complex cardiac history. She has double metal valves, a mitral valve and an aortic valve. We were able to find out where this was done and get the medical records to see exactly what type of valve replacement she had, because that is important. And we found out that she had this because of severe rheumatic valvular disease and endocarditis some time ago. She also had ongoing atrial fibrillation, and she wasn't very good with her follow-up, and because she's migrant moving from place to place around the UK. In her first pregnancy, when she presented to us at about 8 weeks, she was still on warfarin. And that's when she presented with some bleeding. So I picked up the phone and called my hematology colleague because we need to have an MDT discussion with this woman now to talk about her options. We need to get her off the warfarin. And the 3 options we gave her were ideally, off the warfarin. Warfarin is good for you, but it's not good for baby. It is fetotoxic, meaning that can cause harm to baby. but it doesn't protect you because you can have clots on your valve, which can move to brain and other organs and create problems. We can switch your warfarin in the first trimester, put you on low molecular weight heparin, switch to warfarin until 36 weeks, and then back to low molecular weight heparin. We can put you on low molecular weight heparin right throughout. And she chose to remain on low molecular weight heparin right throughout her pregnancy. Warfarin right throughout pregnancy increased the risk. It's better for mom, but it increased significant risk for mother and baby in terms of morbidity and possibly mortality as well. So she went on the low molecular weight heparin, and as we followed her through the pregnancy, we were managing through using anti-10A. It's not ideal, but the results just didn't make sense. She was on very high levels of low molecular weight heparin, and we were getting levels of anti-10A which were not acceptable. So we had to admit her to hospital just to monitor her anticoagulation on anti-10A. And it transpired that she was only taking once a day because she thought that was what she had to do. And so we weren't achieving good levels. We were able to educate her through the use of an interpreter and get her to use the low molecular weight heparin as it should. We got good levels. Our rest of her pregnancy carries through. Now she has severe valvular disease and she has significant cardiac dysfunction. And how do you deliver her? That was also another question. The baby was fine. So the plan was to deliver by a planned cesarean section. Now, I said before, not all medical conditions equal to a cesarean section, but there are some times when this has to be done in order to have control. This is not the patient you want to come into the hospital in the middle of the night with an emergency, have to run to theater. So she had a planned cesarean section, switched to unfractionated heparin, under general anesthesia. Baby was fine. The cesarean section itself was relatively uneventful. 2 weeks after she started reconversion back to warfarin, she had a retroperitoneal clot, which was managed conservatively, and that settled. We looked after her collaboratively with several multidisciplinary meetings between the hematologist, the cardiologist, the obstetric anesthetist, and the maternal medicine consultant. The plan was after this delivery, she would have her valve surgery. But again, she defaulted. Then she presented to us 18 months later, 10 weeks pregnant, haven't had her valve surgery. Her cardiac function was worse with an ejection fraction of 30% and pregnancy of 10 weeks. And I said to her, you have to have a termination. Reluctantly, she agreed. We arranged a termination in hospital in a tertiary center where she was fully cared for. This went uneventful, and 6 months later, she had her valve surgery. This time she had prosthetic valves. So she came back to us very happy, no anticoagulation, no testing every day, pregnancy was fine, and she had an elective cesarean section at 39 weeks. 1 year after the second pregnancy, she had admissions for recurrent bacterial endocarditis and had to have her prosthetic valves redone. At that time, she had septic emboli to her spleen and her brain and to her foot, but she recovered from it, a long morbidity. This woman doesn't have any family. We have to coordinate the care of her children. Do they go into social services? Who's going to look after them when she's in hospital? So you can see the care of this migrant population is not only medical, it's everything. She had her surgery, she went home, and she's with her 2 children now. She's engaging fully with cardiology and no need for anticoagulation, although because of her history of atrial fibrillation, she's on rivaroxaban. So for us, this just highlights the complexity of some of the patients. You see the time you have to spend one patient, right? The time you have to spend with one patient to reduce morbidity, to reduce mortality. She has 2 babies at home, 2 healthy children, and she is engaging with services now. So finally, I like to end by saying maternal medicine is truly stimulating and rewarding specialty and continues to evolve. And we will face challenges in the future, much more than the challenges we are facing now. And we should rise to the challenge. This is St. George's Hospital in Southwest London, and this is my team. And included in this team is our admin support, who takes the patient's calls, gets message onto us. We set up emails, we have group emails, we have WhatsApp, we have a button mobile that is handed to the midwife who happens to be on call that day, so that there's always a place of contact for all the patients that we look after in maternal medicine. Thank you.